Good afternoon, morning, whatever time zone you may be in. Welcome to today's AMA Steps Forward Innovation Academy live discussion titled Integrating Behavioral Health into Non-Primary Care Settings, presented by the BHI Collaborative. I'm your moderator, Chris Bonds, Senior Manager of Care Delivery and Payment here at the AMA. Quickly, disclaimer, please note this disclaimer is for discussion is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Lastly, if you have any general questions or concerns, you can always message our team at practice.sustainability@ama-assn.org. It's now my pleasure to introduce our speakers for today. Joining us today are Dr. Stephen Krebs, Vice President of Care Delivery at the American Society of Clinical Oncology, and Dr. Richard Kovacs, Interim Chief of Cardiovascular Medicine at IU School of Medicine, and Interim Director of the Joint IUH/IUSM Cardiovascular Institute, and Chief Medical Officer of the American College of Cardiology. Here are today's learning objectives. I'm not going to go through and reading all of them, but just underscoring that hopefully by the end of this discussion, you all will better understand the importance of integrated care beyond the primary care setting, be able to identify key barriers and challenges specifically to cardiology and oncology practices, and ultimately identify at least a few actionable strategies that you can utilize to better enable more timely, equitable whole person care for your patients. So today, much of the focus of integrated care has really been on the primary care setting, and it's understandably so, given the clear need for holistic approaches to care for those patients. However, the importance of whole person care does not and should not stop at the primary care door. Other specialists like cardiologists and oncologists also help manage patients with chronic illnesses who have increased risk of exacerbating either existing or developing new co-occurring behavioral health conditions. So with that in mind, first question is, why is whole person care so important to your specific specialties and the patients you serve? Dick, let's start with you first.
Well, thanks, Chris. Thanks for having me and representing the American College of Cardiology. First, I want to clarify a little bit about cardiology today, probably parallels oncology, in that the behavioral health considerations and concerns in cardiology are not uniform. Cardiologists are not a monolith, and what matters to an electrophysiologist may not matter to as much to a interventional cardiologist or a heart failure doc. And just in terms of examples, we see patients come out of the hospital with acute myocardial infarction, and they have a new disease. They're dealing with it. Many of them exhibit signs of depression. So we're dealing with that. But an electrophysiologist may have a patient with an implantable cardioverter defibrillator in place that goes off. It shocks them appropriately. They survive, but they get what amounts to a PTSD for worrying about where's that next shock coming from. So it's cardiology is not a monolith, and we deal with this up and down the spectrum, and we'll probably get into that as we discuss things this afternoon. But it hits us every day. I saw a patient of mine. I'm a general cardiologist, and I had a patient I've cared for many years, and he's got chronic coronary disease, and now he needs a bypass. So I said, we're gonna have you see the surgeon, get you scheduled for bypass now because you've got triple vessel disease and stents aren't enough. And he said to me, Dr. Kovacs, I'm getting a little bit anxious about this. I got to wait. And how do I deal with this? And having something at my fingertips to say, here's how we're going to address this. Here's how we're going to address your anxiety is part and parcel of what we do every day.
Excellent. Steve, anything to add from your all's end?
No, I agree with Dick. Certainly oncologists over the years have become more specialized in certain diseases, and what they have to deal with for the behavioral health is very different depending on the type of disease. And I'll just give a couple examples. You may be taking care of some benign leukemia that doesn't even need to be treated, but just followed. Or you might be taking care of a population of young adults who have a whole different set of issues that lead to behavioral health issues. So yes, I agree with Dick. Depending on what your practice looks like, you're going to have different approaches for behavioral health.
Excellent. So next question, what do you feel is needed to better enable and sustain whole person health moving forward? Steve, let's start with you, and then Dick, we'll move over to you.
You know, one of the things that all of us like to do is follow standards. And I think we need to evolve standards in our specialties of how to best approach behavior health. And that leads to the first part of that is we probably need more good trials and evidence to help establish the very best standards to follow, folks. So I would say if I were going to ring up one of the things to come out of this today is really push a little harder to have maybe some more research done that'll help us establish the right standards. And as I said, it may be very different from different specialties, but I think that's an area that we really need to work on. You know, I can tell you at ASCO, we had one little study that was done that just showed that if you spend 15 to 20 minutes, you know, talking to a patient about their psychological situation at the time, it made an impactful effect on the patient. So I think we just need more of that. The second thing we really need to learn to do better, and I think we're going to talk about that more today, is how we actually implement these standards and findings we have. And to me, that's been one of the key things I've tried to do at ASCO, is try to move us away from just knowledge to actually implementation. Because we don't implement what we've learned, no one benefits from it. So we can't stop with just saying, hey, we learned something, we have a standard. We have to learn how our practices can actually then utilize these ideas and tools as we develop them. So I think that's important. And I'll put a third one on the list too. Once you're involved in whatever it is, in this case, behavioral health, you have to do continuous quality improvement. You have to continue to monitor, how are you doing? Where do I have gaps and how do I do it better? So all three of those elements, I think, will promote where we want to be in the future.
Absolutely. I think we've seen a lot of that in the primary care space, and I think we're looking to see more of that in some of these other areas. Dick?
Well, check, and check. You know, cardiology, like oncology, we like to follow clinical guidelines. So developing the rigorous evidence that is needed to influence our guidelines, it's a tall order, and it will take a lot of effort and work to get that kind of evidence. In addition, cardiologists are, you know, all specialties are very busy, and fitting into the workflow, I think, is important. The kinds of things that have to go on, you know, we're working through this right now in my own institution, and being able to fit a warm handoff into the workflow makes such a difference, as opposed to, I'm going to refer you to X, Y, or Z clinic for treatment of, you know, A, B, or C, you know, as opposed to, you know, here, let me introduce you to, you know, to practitioner X, Y, or Z that's going to help you with your anxiety about undergoing coronary bypass surgery. I think is a big. And then I think third is, in addition, is a professional education, and along with the professional education, the patient education, and the patient-facing tools, to realize that coming to the specialist office may involve, you know, care for your behavioral health issues.
Yeah, I think these are really great points, especially the warm handoff piece, right? It really needs to feel integrated and connected rather than yet another separate referral or separating this from the rest of the part of care that can really just exacerbate a lot of these issues. Before getting to the next,
if I can add to that,
yeah,
I think
go ahead.
Dick brought up, I think, a really important point. This is all dependent on good team-based care. We have to take advantage of the teams we build. You know, I think we've all learned in this new world, you just can't do it by yourself. So you have to have a well-designed, efficient team to be able to make these handoffs, be able to recognize the problems, and as a team, take care of this. So I think that's a key part of this, is really building the team.
Yeah, and I think it's education on both sides of that team, right? To understand how this works, the goals, similar language, that understanding really helps facilitate, right, that smooth processes for those patients that are desperate for a lot of this care. Before getting to the next question, we did get a clarifying question from the audience that I wanted to see if you all can quickly answer to help differentiate between just behavioral health and psychopathology when it comes to these conditions. Do you all have any just clarifying thoughts on that piece before we get into further details of some of these aspects?
Well, I'll take a crack at it because I ticked a couple down the list of issues versus psychopathology, but our valve teams. So we have now teams of clinicians, surgeons and cardiologists and nurses and who are taking care of people with valvular heart disease. And one of the most difficult populations to take care of with valvular heart disease are patients who have opiate use disorders, inject IV drugs, get infective endocarditis, come in and get a valve, and then, oh, by the way, the opiate use disorder is not dealt with properly, or not, they come back and there's a high rate of recidivism, and they come back for their second valve and their third valve, and then you get into ethical dilemmas. So each of our specialties has, unique pathology, unique pathologies that we have to deal with. Some quite profound. Somebody out shooting heroin or fentanyl up in the bathroom of their hospital room is a bit different than maybe my 20-year patient who's anxious about undergoing a major cardiac surgery. So that's one differential. But you have to know what you're dealing with, and how long you're going to be dealing with it as well. I'll give it just another vignette. Our adult congenital heart disease, or congenital heart disease in general. I mean, I'm an adult cardiologist, and maybe people don't realize now there are more adults with congenital heart disease in the United States than there are kids with congenital heart disease, because we're doing better and they live longer, but they're living with a lifetime of congenital heart disease and multiple surgeries and all the morbidities that go along with that. So you also have to look at the long-term effects on pathology as well. So I hope that helps with that. Steve, you got...
If that last subject, fits with us in oncology very much, our survivorship work we have to do. You may have been treated, but you're now a survivor, and it has a whole nother set of implications. And, and I agree with you on that. I think really significant psychiatric disease and things that lead to that is probably beyond the scope as a medical oncologist of what I can handle. But the usual behavioral health things are things we have to identify and either do what we can or get the right people. And I want to we didn't want to go in this direction, but I just want to say behavioral health does not live by itself. It's integrated to everything that's going on with the patient and all the stressors in their life that are even more than just the diseases they're dealing with. And you really cannot separate them. And what they have is stressors in their life leads to more behavioral health. And as you begin to evaluate this, you have to look at everything around them. And I'll use the example in oncology. The number one stressor when people get diagnosed with cancer is financial stress. All the things that lead to financial issues with the treatment and loss of work and family involved and all that. And once that stress begins to go up, behavioral health issues then actually multiply. So we can't separate this from all the other stressors, whether the social determinants of health or other ones for patients. And I'm just going to use an example because I know we're going to get to this. Our practices we're working with are using a device or a thing from the NCCN, the National Comprehensive Cancer Network, which is a distress thermometer. And it kind of mixes in these types of distresses with also behavioral health issues. And you have to attack both to make a difference for the patient and their family.
Absolutely. Well, I appreciate you all helping clarify folks so folks can have a better understanding kind of the aspects we're talking about as we're using some of this terminology. So, thinking forward, right, I think we heard a little bit about this in the prior question, but what does the ideal state look like for integrated whole person care within each of your all specialties? I know you all touched on certain kind of components, but are there any additional details of kind of like what those aspects really look like within cardiology practice or oncology practices?
Well, I can take a shot at that first. One of the things that we've worked hard at ASCO, and I'm going to say really over the last 5 to 7 years, is redesigning what we think is the optimal outpatient oncology care delivery system. And I'll use the word, it's used a lot, it's a patient-centered approach. And I bring that up because I hear people talking all the time about patient-centered care, but we've actually tried to identify that, and as Dick pointed out, with discrete standards and things you have to do to provide this patient-centered care for a patient and their family. And integrally involved in that is some of the things we've already talked about, but behavioral health issues, survivorship issues, and it goes on and on and on, looking at their stressors in life, as well as the medical things we have to do to combat cancer. So we've actually developed a certification program for this, and it's built in a way to not only have good patient-centered care that includes behavioral health, but it also has been built to deal with, as a changing system, if we get there, into value-based medicine, because all these components are going to be very important to come up with a value-based medicine program.
Well, and I've got a sort of the other view. You mentioned, oncology is a heavily outpatient-based specialty. Cardiology is both inpatient and outpatient, and one of the things that we are wrestling with right now is that that transition from inpatient, because so often on the inpatient side, the patient comes in acutely ill, requires hospitalization, requires intervention, or whatever, and now we're dealing with a whole set of new stressors, and making that transition from the inpatient to the outpatient, making that smooth transition, making sure that our inpatient teams introduce the patient to this idea that we're going to take care of all of them, the whole situation, the whole person, and what we start on the inpatient side will continue on the outpatient side. And as we all know, again, and I'm a broken record on this, but the handoff and the personalization of that, not, we're going to refer you to clinic. Okay. And when somebody says clinic to me, I think of uncomfortable plastic chairs in a waiting room with bad lighting. And no, you're going to go see, you're going to go see my psychology colleague. I'll name my psychology colleague, Jesse Stewart. You're going to go see Jesse, and he's going to start to help you with dealing with some of the stuff that you're under stress with. So, agree with everything Steve said, and add on this added layer of complexity of the inpatient to outpatient transition that we have to deal with all the time.
Right.
And then back to outpatient.
And Dick, I was going to say, I think you have a key thing there is the personalization of how you refer your patients. And I used to say that in practice. I don't refer people to bricks and mortar. I don't send them to clinics. I send them to a person I know, and they want to meet that person. I refer to other physicians, psychologists, whatever. I don't refer to a clinic.
Yeah, and we've talked about the logistics of this, and we're actually in clinic space is clinic space. Finding a place for the provider, for the health professional, the behavioral health professional, to be able to be there, meet with the patient, be available to do a warm handoff. You got to think ahead and how you're going to do that, because many of our clinics are stretched for space. I also attend at our city county hospital, where we have a whole different where the clinics are plastic chairs, and but we need to provide the same level of care in whatever setting we're at.
I think you all started getting into, right? I think these opportunities are great, but we all know it's not necessarily all happening now, and there's certain challenges or barriers that are making that or complicated, either complicating those warm handoffs or whatever it may be. Can you talk a little bit about some of the challenges either you all have faced in trying to do this in your own clinical practices, or what you've heard from your members? And then maybe touching on if there's any opportunities or things you've heard about ways to try to address some of those, in your experiences or conversations with your members.
I'll take first shot at that, I think, and Dick hit some of this. We talked about team-based care. So I think one of the first issues practices have to deal with is how do you prioritize screening and measuring behavioral health issues, and what tools are you going to use, and how do you put that into the workflow that it actually happens on a regular basis, and do your best not to increase the administrative burden on your team. I mean, that is a challenge every practice has to face, but that doesn't happen until you make this a priority in how you're going to take care of folks. So the other issue, again, working with some of the practices, how do we best assess the right tools for them to use? Because there's all kinds of tools out there to help you measure and see where folks are on behavioral health. And, we have all these ePros that are coming on board. How do we assess them? And that's a whole nother story, how you integrate those into your workflow. And then the final thing I would say is, a major challenge, when you're not in a big institution, even there it's a challenge. Certainly if you're in a community-based practice, do you have the resources in the community to help you address the behavioral health issues? Because an independent practice doesn't have the abilities to actually support an entire behavioral health program within the practice economically. So do you have the resources outside of the walls of your practice to make those personal handoffs that Dick has described so well?
Yeah, we've heard a lot about one, and we talk about this a lot on the primary care side too, right? Leverage what already exists. Don't reinvent the wheel if something already exists. And that's a really important piece of that, Dick.
Well, I wasn't going to sugarcoat. Many people listening know cardiologists, and some cardiologists aren't quite as attuned to this. So another barrier is we just have to make sure that our specialty is aligned in this, that both nationally as a specialty, but also locally in the practices, that you don't have the naysayer come in and say, well, this, that's fine. I fixed the coronary. We're done. To heck with the rest of this. So we do have that. And one of the powerful things that has happened organically in cardiology is at the college now, we have actually a group. We have a mechanism called sections. So we have a pediatric section, and we have a sports cardiology section. We have cardio-oncology section. Or I'm supposed to say oncocardiology, right, Steve? So
it works either way. As long as you're seeing the patients, it works either way.
So we have these, but we now have a group of cardiologists around the country who want to solve these problems and remove these barriers, and are forming a section within the college related to behavioral health, psychology, psychiatry, to do this. So I think that'll go a long way. Limit the naysayers, unite the folks that want to do this as well, to remove some of the barriers. But regardless, we still have hurdles to cross.
Steve, I want to come back to a couple pieces that you all have talked about. One, Dick, your point about just increasing the awareness and education, right, and the importance to do this, right, within your own specific specialties. I think there's just a recognition, part of the reason why we're having this discussion, right, to help facilitate that conversation. And the second piece, Steve, that you talked about was, so many of these practices have so many priorities, right, they're trying to balance, right? There's the triple aim, then the quadruple aim, quintuple aim, right? All these different kind of pieces. How do you think about these practices prioritizing or navigating all these kind of pressures, including, right, the inclusion of, recognizing this importance, being able to actually create space to address it and find ways to do that can be additive to their practices and services they provide?
Yeah, I think one of the key first steps is to get a practice champion. you have to have a champion within the practice that drives this and brings it home. If you don't, it's just going to, be there and maybe not. But you have to have a person that makes sure that this becomes then a priority in the practice and uses all the tools they have and the education they have to bring the team along and to implement it properly. So I think that's really one of the really first key steps in the entire thing. And then I think once that happens, you need to then be able to present to the practice as you begin to implement tools and what happens when you implement them and the effect it has on the patients in the practice, because there are certainly major upside gains as you have better behavioral health with your patients, let alone just a better patient experience. So I think you need to do that. And then I think along with that is you have to tie that in, as I mentioned earlier, continuous quality improvement. But I think it all comes back to having a champion that makes the practice aware and monitors and has the practice proceed along a pathway to better behavioral health management.
Yeah, and core pieces of that, right, is collecting that data, right, from identification screening, right, to be able to measure and track that over time. And even within primary care, measurement-based care and those types of things aren't necessarily always standardized. And I think that's an important piece of these settings.
And I suspect Dick has had the same experience I've had. When you present physicians with hard data, they respond.
Yep.
I agree with you about having the champion. It's needed. I agree with the data. Having the data. I also take advantage of those sort of teachable moments, and even if there's an anecdotal good outcome, just really advertise that especially to deal with some of the folks that may be resistant to this in a practice as well. But I'm going to make another point in terms of the continuous quality improvement and the proof of the worth of this. We're trying to work hard to align with larger goals, and cardiology's looked to a lot in the hospital to reduce readmissions, to reduce mortality, because we drive a lot of that in hospitals. Heart failure patients are readmitted to the hospital a lot. Coronary disease patients are readmitted to the hospital a lot. So we're trying to build that evidence base as we build programs to prove that we're making a difference in those global measures that our entire health system cares about. So we don't have to isolate it that this is good for cardiology, but this is good for the system because our heart failure patients are having their needs, their behavioral health needs dealt with, and they're not coming back to the hospital because they're dealing with it. They're dealing with it in our outpatient settings.
Right.
Yeah. And I know that.
I'm just going to comment on that. I think what we're seeing as we see our practices that have really delved into this, that the patients begin to get the sense they have a lifeline of a place they can go to get the help. And they're not just sitting out there ending up in the emergency room and elsewhere. So I really do think that whole patient-centeredness and knowing that your cardiology practice or your oncology practice is there to help you in all these aspects does make a big difference.
And I know we haven't raised this, but I was talking to some colleagues about this the other day, and in the usual hallway. And oh, by the way, who comes up but the chaplain? and the chaplain says, "Would like to help with it. Would like to help with this. We do this. We deal with this kind of stuff all the time." And I know, they said. People are winding back up in the ER because they're not connected or they're lonely or they can't get their medicines or whatever. So this can be a nucleus for a lot of other people that I hadn't thought about. I hadn't thought about the chaplain in all this, but they were ready, willing, and able and said, "This is a great idea. We think this is great. And how can we help?"
Yeah, I think, one of the other things that we've talked a little bit about, it's great to have someone who's spearheading these conversations, right? But also being able to empower them with that data, both internally within the system, but I think broadly in general, that just underscores the value, right, of doing this. It really helps them facilitate those conversations And I think, based on what we've talked about, there's still some opportunity right there in each of your specialty areas to strengthen some of that research and data that will help those folks be more empowered, right, to have some of these conversations. Any thoughts about that part?
Well, I'll take that first. The program that we're building. I mentioned Jesse Stewart. Jesse's a member of our psychology faculty. I've worked with him on federally funded grants, and we're building a pilot, program within our division. But we're building with the idea that the research and the data are going to be from, we're starting this formally in 2025, and from the get-go, we're going to build in the data acquisition with the idea that we can get preliminary data, we can write grants, we can build the evidence base, we can convince not only our own institution but the rest of the country that this is the right thing to do. So I think it is integrated. And it's important to have, if you're in an academic center, to have that linkage built. You mentioned, Chris, at the start. I run the CV Institute for IU Health and the School of Medicine, and that institute is dedicated to the intersection of the academic faculty and the health system to try to drive improvement and change and good things for the system. So this is right at the sweet spot of that. And we need to be able to translate that and transfer that into our health systems, large, practices that aren't at the academic health center. So but call me back in a year. I'll tell you how it's going. But we're going to build the data acquisition and the research in from the front, right from the start.
That's great. And Dick, one of the things we've been doing to try to get the implementation to occur, which is where you want to get this, is as we build our network out of these patient-centered practices we've identified, they form a learning collaborative, and they meet monthly and they discuss different topics. Then it may be behavioral health, and they share their implementation experiences and learn from each other in that. And I guess you call that best practices. And within our network, we have academic centers, we have independent practices as small as 4 oncologists, some as big as 100, and they all learn from each other. It's really bi-directional between the academic docs and the community-based practices. So I think that's been I don't think when we started these that I recognized what a powerful tool that is to have these learning collaboratives discussing what they're doing and how they're doing it. And the other part of that is the practices that have done quality improvement projects on behavioral health. We encourage them to publish what they've done. And I know I have at least 3 practices that have published at least abstracts on their quality improvement, and that's available for anybody to look at, the problem they had with behavioral health within their practice and how they solved it. So I think those are the types of things that we can get at that are on the implementation side once we know what the right things are we should be doing.
Absolutely.
You raise a real important point, Steve, about the learning collaboratives, and I want to make one point, because maybe I came off as the ivory tower guy. That four person group can often teach very important lessons to the academic folks, because they say, here's what it's really like. Have you thought of this? And the learning collaboratives and just facilitating that interchange of ideas and information and what works and what doesn't is really critical.
Right. And the one part of this, one has to be flexible in a practice how you get this done, because every practice is different. And part of that is we certainly should not be telling people how to do it. We should be helping them do it and have them find their own way for their type of practice, not to be prescriptive about it.
Absolutely. I think we've talked about some really great kind of best practices or some opportunities. Are there any others that you all can think of that people should be thinking about in terms of either actually operationalizing, right, some of this kind of integrated care, or just ways to strategize in terms of implementation or workflow design or anything like that? Are there any other thoughts that you all have that would be helpful for folks to think about as they're considering these efforts?
I think if you've made this a priority and you have buy-in on that, the first big step is really getting in place the screening modalities to actually generate the information you need then to take action on it. And then, of course, you go from there. How did I do with that? But if you're not screening properly and figuring out when is the right time to screen, and it shouldn't just be once in the lifetime of an encounter with your patient, it should be periodically done. And I know in our practices, the first big one when a new patient comes in is the screening when they first come in prior to their first treatment. And before they get to the treatment, you build basically a baseline of what the behavioral health issues are that then can change as you get into treatment and deal with the toxicities we have to deal with and the stresses of, good results versus bad results, and eventually getting to end of lifetime. So those are all things to start with. And I say, get the screening going, know when to do it, and really establish a baseline before you really get too involved in the management of a long-term issue because cancer is a chronic disease, just like heart disease now.
I would agree. The screening is ditto on our side to understand what the baseline is, and as I mentioned, it gets particularly problematic when you especially take somebody who's had a diagnosis made because of an acute event and they're an inpatient, and then as I mentioned before, they're moving to the outpatient arena, and there's all this stuff going on. So much stuff has changed. When do I get to go back to work? What's wrong with me? What's going to happen to me? What the expense of this? I'm all these new medicines. I've got all this follow-up. So establishing what are the issues that we are going to address, I think is critical. And again, it depends on where you're practicing this. On the outpatient side, one thing we've leaned very heavily on our primary care folks who have covered this path before us. So I'm leaning on my colleagues in primary care a lot so I don't make mistakes that they can help me avoid.
One of the things we heard often in primary care, right, is obviously the importance of screening, but what comes next, right, from screening and the capacity and having some of those things identified and set up, right, because there needs to be a pathway forward if there's a positive or other type of concern based on some of those screening tools. So I think that's a clear part of what we've heard in primary care, and I think it seems relevant to your all's practice settings as well. So I think we'll move to some of the Q&A questions that we've received from folks. Just as a reminder, if you have any questions, please submit them into the chat and we'll get to as many as we can. We received a lot even before today's discussion, so we're going to try to get to them. But if we don't, we'll do our best to circle back with folks to help identify them. So one question we did receive is, currently, as I talked about in my opening comments, a lot of behavioral health integration happens in the primary care setting. And one of the treatment options within primary care within these settings is the prescription of psychotropic medications. How comfortable are you all, your colleagues, with doing so within your all specific specialty areas?
Well, I'll take that first. Your cardiologists, they're going to get all sweaty when this happens. But I guess it's probably been 3 or 4 years ago. Suddenly, cardiologists were faced with all these new diabetes drugs, which, oh, by the way, are good for your heart. So we're giving them to all our heart failure patients and our coronary disease patients and our metabolically impaired patients. So 4 years ago, if I walked into to a practice and said, "Are you ready to start prescribing diabetes drugs?" They would have said, "I'm not a diabetologist. I'm not going to do it. Let somebody else do it." But in a very short time, because because they've been shown to have such benefit for the patients, they're being prescribed routinely and comfortably, and side effects are being dealt with. So we're not there yet with this class of drugs, but I have confidence that the cardiology community can adapt to this, especially and critically if there are good clinical data to tell them that their patients are going to be better off for it.
No, I would agree for oncologists. Dick and I chatted about this earlier. I remind everybody we are internists as well as specialists. So yes, I think I'll call it the less intense behavioral health issues, I think certainly my colleagues are well versed to use medications for that. I think the other part of that is knowing who takes care of your patient. And if you have a primary care physician who very much wants to be involved in the care of a cancer patient and they're accessible, that would be something I would clearly have them involved with. If I don't have that type of situation, then it's up to me to either start managing it or get them to someone who can manage it better than I. But I think in general, for mild behavioral health issues, I think most of us can manage that fairly well.
And I'll put a coda on that as one thing I've learned from talking to the primary care folks that have trod this path before us is, there was reticence about doing this out of the primary care, out of some primary care offices as well, but they learned, take it step by step, but also develop a network where if the wheels are coming off, that you've got somebody that you can access, somebody more expert in the pharmacology than me, to say, oh, here's advice on that, or here's where that patient should go, and build that in, because there's going to be some natural, reticence, anxiety about am I overstepping what I know in terms of pharmacology.
We've seen a lot of that on the e-consult side of things as well, right? As a huge way to help facilitate some of that coordination and education as well. Sorry, Steve, didn't mean to cut you off.
No, I was going to say, and I think in the relationship I've had with my primary care physicians, the key part of that is, taking care of a complex cancer problem with all the toxicities we cause and all that, is working with the primary care doc and delineating, hey, here's what you can manage. I'll take care of the other stuff. Don't worry about it. But if you can handle this part of the problem, I've got you covered on the rest. And I think that clear delineation between myself and the primary care physician, who's responsible for what, I think makes things happen a lot better.
You all must be seeing some of these questions, because that was some of the follow-up questions as well, as how do you think about, right, the coordination between primary care and what efforts they may be doing as well on this topic area, as well as other behavioral health clinicians, right, or that may also be part of this process. And how do you think about that true team-based dynamics and having those kind of conversations? So I think that's really, really helpful. So I'm not surprised that this question came up. So gonna throw it out to you all, but the question is basically thoughts on best arguments for financial sustainability. We know behavioral health reimbursements doesn't necessarily always flow with medical reimbursements. Providing downstream revenues or showing QI results is great. However, the medical side, to argue on behavioral health reimbursement isn't always an easy conversation to have. Any thoughts about key aspects about financial arguments, particularly trying to delineate the values across the board, even if, right, much of the conversation may be not on the behavioral health side of things in terms of the support you all are typically providing?
Well, I'll take first shot at that, and I think Dick was already implying this. We need to generate hard data that shows better behavioral health leads to less costly care. And his example was good behavioral health with heart failure patients reduces emergency room or hospitalization length of stay. And we're seeing the same things in oncology. And the problem is we got to generate that data and show it that good behavioral health with the patient-centered approach cuts down on emergency room, it cuts down on admissions to the hospital, and ends up with patient better patient experience. And I think we need to generate that data. And I hate to say it, but when I talk to payers, they all say, yeah, that's great quality care. But unless their actuaries get excited about it, things don't happen. And I think that gets back to one of the points in all this as we begin to continue to work through this. This is where we can really need strong advocacy to promote this and get the reimbursement we need. And this is just one of many topics we all have in medicine that we do that do not get reimbursed well, but it's just one of many. And it's going to require advocacy, but advocacy needs facts to go with it to persuade people. And we just need to generate more of that.
I agree. And I do think, the American College of Cardiology, we advocate for our patients, and we advocate for fair payment for our members, and those are not mutually exclusive. So we want to be fair, fairly reimbursed for these kinds of things, and we realize that all of these issues, this is a slog. Any advocacy effort is a long-term effort. You repeat yourself over and over and over and over again. But this is probably also an area where specialty societies are stronger together than we are apart. Unified messaging between organizations like Steve's and mine, so that we can come with one voice and say, this is important, this makes a difference, here are the data. So we should be cognizant and careful to make sure that where we can be united, because so often in these advocacy areas, the payers like to divide us, right? They want to
Absolutely
pit one against the other, but here if we come shoulder to shoulder, I think we'll be a better force for good.
And I think that shows that, the value of what we're trying to accomplish through the collaborative, right, is creating that more unified voice, alignment across these different settings, because these needs, unfortunately, the financial sustainability piece is not just unique, right, to this settings. It's really across all integrated care because of the separation, right, between some of these different systems and products, unfortunately separating out some of these kind of services. And I think, Steve, you're the ones that talked about that. You can't really separate these conversations with your patients. It doesn't make sense. There's an interplay there, and the payment should follow suit. So it's a conversation we continue to have across the board, payers, policymakers, et cetera. It's a high priority for our efforts as well. Another kind of more specific question we received was, any thoughts on using clinical decision support tools to better integrate behavioral health care within your all specific settings?
Well, I have just the first premise here. Quality of care is going to be driven by technology, and they're integrally related to each other. So again, I think as the world in medicine and all specialties and primary care become more and more complex, we really need to have decision support tools for everything under the sun. Otherwise, you just get inundated. So yes, as I haven't seen recently anything, but if we had really good decision support tools that got plugged in with the screening for behavioral health, I think that would, again, allow the team to be much more efficient in approaching the problems.
I would agree that technology is going to play into this in a strong way, and maybe not a clinical decision support tool per se, but I think in cardiology, as we're looking at leveraging technology, we're also looking at it to help us triage. To this is a patient with a more acute need, as opposed this patient's need is less acute, and raising that up so that the frontline clinician has assistance to recognizing, there are a lot of signals going off here that say this is somebody in which action is really needed. not exactly clinical decision support, kind of clinical decision support, at least, consider this diagnosis. This is bells and whistles are going off here.
An example of that in oncology that can be put into behavioral health is the same idea. We have some software now that will make a prediction on patients, how they start with their chemotherapy, who are the ones that are most likely to have significant toxicities and end up in the hospital. And therefore, you can triage and monitor them much more closely at home to avoid the problem. I could see the same thing being developed in behavioral health. Have a system that says, all right, here's a person at risk. I mean, maybe you can figure that out, but really clarifies it and then changes your approach of how you're going to be dealing with monitoring them for behavioral health and getting them the resources they need.
Absolutely. So, I think this is a really critical topic for those folks that are already currently in practice, but we hear a lot about medical education as well, right? Increasing the awareness and understanding of practicing in this kind of way. So for one of the questions we received is around residents, particularly those that may be specializing in psychiatry. How should they be thinking about preparing for non-primary care roles, right? In terms of the role they play in this specific space. I think there's a lot of assumption, right, that some of those efforts would be happening in primary care, but what do you think about how they should be thinking about their efforts in other settings?
My first recommendation, I know it's hard to do, is have them spend some time with Dick and I in our offices and in our clinics and actually see the issues and see what needs to get fixed. And I think you'll find maybe some new interest comes out as you begin to see the issues that Dick and I have to deal with day after day.
I would agree. So there probably is room. We don't want to create another workforce crisis by siphoning off patients or providers to work in the specialty offices, but it has a certain attraction. It could lead. I mean, there may well be academic careers that could be built on this field. This is, we always tell our residents, find your niche, and this is somebody has an opportunity to get their foot in the door when it's just starting to open and really make a career out of this. So there's that aspect as well.
Excellent. So I know we're starting to run up on time. Apologize for everybody. I know we've got a ton of questions. But before we close out, wanted to give you all both some space to provide any last advice, thoughts, perspectives to colleagues of yours, others, right? They're looking to work in this specific area as they look to either start or continue their journeys in integrated care.
Well, I can start. I'm a big fan of my professional organization. People who are interested in this. I said we already have this. We have an affinity group, learning communities. Learn more about this. Educate yourself about this. Talk to your primary care colleagues that have been down the road, and we'll keep the momentum going in cardiology.
Well, I would say for the American Society of Clinical Oncology, I think we have recognized the importance of behavioral health through the whole continuum of care of our patients, from first diagnosis through therapy, through survivorship, and even at the hard time of end of life. And it's just not the patient, it's their entire family and caregivers around them. So I think we all have recognized how important that is for us. And as we said, the key thing is learning how to implement things in practice that'll actually make a difference for folks. And again, I think that's the approach we're moving on right now is patient-centered care, and this has got to be a key part of it. And as we see practices endorse this and then bring this on board, we are seeing that behavioral health is a key element, and practices are quite satisfied that they see better patient experience and they believe better outcomes on their patients and their families. So highly recommend we keep moving in this direction.
Absolutely. Well, I just want to thank you all both again, knowing how busy you are, and just really thrilled. I hopefully folks found this discussion valuable and really excited to continue these discussions within the collaborative and elsewhere, right? To take a lot of these items and put it into practice and really creating a sustainable approach, right, to doing integrated care across these settings. So just really wanted to thank you all again for your time. For those folks that may have additional questions or concerns, please reach out to the email that's on the slide, praxissustainability@ama.assn.org. I also recognize that we weren't able to get to everybody's questions, so feel free to reach out to us and we'll do our best our can to facilitate answers to those. Please also, for a full list of other offerings that the collaborative has from previous recordings, follow the QR code that's on here for our YouTube playlist that includes a number of different topic areas, from coding to health equity to all sorts of different topic areas. I think we're up to 25, maybe even 30 at this point, so please check those out. The collaborative also has the BHI Compendium, which is a helpful framework for those folks interested in the space that really helps making effective implementation of BHI a reality, which also includes additional hyperlinks to other resources from other organizations that have done a lot of work in this space. The AMA also has a number of specific how-to guides on specific topic areas, ranging from workflow design and substance use disorder and suicide prevention. So please check those out if of interest to you. And finally, just wanted to note that you can register for upcoming BHI Collaborative webinars from the AMA Steps Forward Innovation Academy by scanning this QR code on the slide here. Also wanted to note that there is a survey widget on your screen somewhere, so please fill that out. That's really important for us to help improve these efforts moving forward. So just wanted, again, Steve, Dick, thank you all again for your time, and for all of you for joining us today with this important discussion, and looking forward to continuing this momentum to try to make this a more standard prior practice moving forward. So just thank you all so much.
Thanks for having us.
Thanks, Chris. Great discussion.